Hello.
Καλημέρα σας. Έχουμε την τιμή με τον κύριο Κουναλάκη να προεδρεύουμε σε μια πολύ ενδιαφέρουσα συνεδρία με τίτλο «Τα προαπαιτούμενα για τη λειτουργία της τηλεϊατρικής και του mobile health και τις βέλτιστες πρακτικές». Έχουμε μια σειρά από διεθνούς φήμης ομιλητές από διάφορες χώρες που θα μας παρουσιάσουν τις βέλτιστες πρακτικές τους. Καθότι οι περισσότεροι από αυτούς είναι από το εξωτερικό, η συνεδρία αυτή θα διεξαχθεί στα αγγλικά. Παρ' όλα αυτά υπάρχει χωριστό κανάλι που μπορείτε να παρακολουθήσετε στα ελληνικά για όσους εκτιμάτε ότι δεν μπορείτε να το παρακολουθήσετε στα αγγλικά. Οδηγίες νομίζω θα σας δοθούν στο chat room. Dear friends, it's an honor for me and Dimitris to have you all here together with us in Greece in that important Greek health economics and policy conference, which happens every year at the end of each year in Greece, and it's more or less always a guidance to what will happen on the healthcare sector for the next year to come. So during this year, there is a specific track on digital transformation, and this session is part of this track. The scope of it is to present to the Greek audience and to the Greek decision makers good practices around the world, especially in the domain of telemedicine and mobile health. So I would like to give the floor to Dimitris to say maybe one or two words, and then we can probably start with the first speaker.
Hello, just not to welcome all. I think we should have a good view about what happens in the whole Europe. I don't want to take time because we are already late. So let's start, Alexandros, and we'll talk to the last.
Okay, so let's go with our first speaker, which is Viktor Van Haagen from MedMij from the Netherlands. Victor will explain a little bit how the MedMij program has been organized and how mobile health has been, let's say, structured from all the points in this country, which is one of the leading countries in that domain. So, Victor, the floor is yours. Please try to keep your presentation around 10 to 12 minutes so that we have enough time for discussion afterwards.
Thank you for the expectation on the time. Can I share my screen?
Yes, please share your screen and also open your camera, please.
Okay. Right. Let's see, share. Do you see my screen now?
Yes.
Yes. Okay, thank you. Welcome everybody to join me at this session about the Dutch approach towards sustainable framework for personal health environments. I'm alone. Vincent van Pelt is a colleague of mine. He may be joined later, but we'll see. Why isn't it? Yep, it's moving. I'll have 10 minutes, so I'll go a little bit fast maybe, but if there are any questions, please ask them later, no problem. In Holland, there's still increasing evidence that well-informed and decision-making individuals contribute to meaningful care and experience a better quality of life. So in Holland, we see this as the opportunity to start a new kind of health exchange information between the individuals and care providers. So it used to be a little bit more like a one-way street, and now we see that there's more a network starting to develop between those individuals and the care providers. And that's why MedMij has started. MedMij makes it possible. It's a program, MedMij. It makes it possible to combine the health data safely and reliable in your own personal health environment, and sort of a new mobile-based dossier for people to access their health data from different kind of care providers. So what's its the definition in Holland of the PHE. Well, it is personal health environment. It's a lifelong tool to collect, manage, and share the health data in one place so that you can take more control over your own health. It should provide a new kind of interaction with the health providers. Why is this important? Well, insight is important. That's what people say. Taking control and integrate your information in one place. It's now scattered around different sources, and they say it should be in one source. A lot of people in Holland just want to see one place where they know where everything is found about their health. And they're also helping the caregivers getting access to that information quicker. That's the idea about MedMij. So it's not only a place where it's collected, it is also a place where you can distribute from. So now it's more like an individual one-to-one situation, and it needs to go to a more kind of network. And that's what MedMij wants to achieve in Holland. The core tasks of MedMij, those are to facilitate those digital exchange of the health data between the residents of the Netherlands and the healthcare providers. But it's also creating confidence that is done in a safe and sustainable and affordable and user-friendly way. Especially affordable and user-friendly is our main goals, because you have all these e-health apps and people need to pay for them. And so we want to make them affordable with low costs, and it needs to be more user-friendly. Not everybody can use a mobile device, elderly people, people with a language difficulty. So we want to do it as friendly as possible in Holland. But there are portals with information connected to individual caretakers. So we're now also developing the PHE to be a little bit better than the portals. The access of one is need to be the access to several caretakers. Again, when it's connected to one care provider, there's not really a freedom of choice. With the PHE, it's the intent is that you can access different care providers, so you don't have only one portal. There's some other benefits on the slide. The slides will, of course, be available for everybody. How will this work? Now, MedMij will be working in a framework, and I will explain a little bit what you see here. You see that at the base of it are a set of agreements with participants in this framework. And you see two types of participants, the PHE side of it on the right, and I will show the left, where the caretakers are. The caretakers themselves aren't connected into the framework. They are helped by a service provider that will make the connection with the source of their own systems, their own interface for their own place where they're put in their information. So they have a service provider that will make that connection. In Holland, we decided to take FHIR as the connection between the person and the service provider for the care provider, because this is a much more efficient language to use in the mobile world, and it's an international standard that is going very fast, so we can learn a lot with more people than just our own solution. I will go through these quite quickly. Oh, excuse me, this was a little bit too quick. What does the framework do? It states which parties fulfill the roles of the data exchange. There are agreements between these parties about the rights, the obligations, the incentive, the sanctions, of course, because it needs to be a safe place for the exchange. If it goes wrong, there are sanctions. But of course, before sanctions and everything, we also do certifications and testing. So we are very confident that the information comes with that it will be okay when the information goes through. I will go a little bit faster because of the time. The priorities are, of course, that there is a right to the data access. That's also in the law now in Holland. So care providers, if a person asks for their data, they need to share it. A PHE is the best way, we think, at MedMij. You also need consent, and it's citizens have to agree to share the information. If one PHE doesn't work, you should make a free choice to go to another one with the same access to the data. It needs to be convenient and, of course, safe and reliable. Is very important. But it's not the only participant in this for MedMij. Also, the caregiver, care provider are very important, and they need to be assured that what will happen with the day-to-day register is also not going anywhere but the patient, the citizen of Holland. So the file he makes, the dossier he is responsible for is still his file. A PHE isn't also a medical file. It's a view into the file. So it has no status as a medical file. There are no access to individual notes, so private messages to other caregivers are secured, that people won't see them. And of course, law and regulations are also taken care of. Again, one of the things that is very important in this is that we think that the dialogue in the consultation room will change when people have access to the same information. Things will go faster is the idea, and healthcare will be less expensive. The financing system for this all, it's funded by the government in Holland. And there are two ways the funding goes. It's for the individual side of it, which is for the PHEs. It's a sort of stimulus, and then continuous stimulus and a sort of structural finance, but also at the care side, because it's a movement to change the healthcare system in Holland, and the care providers have another, their dynamics and their change rate is sometimes different between those domains. So there is a funding for all those domains, which is more close to how quick they can change. All in a whole, over 500 million euros is put into this system to make it work. We work with a lot of standards in Holland to provide the information, and we're very proud to show this, because on the patient side on the right, that's the person who wants to see into all the information, and the PHE is already can access all these dossiers you see here in Holland. So we're very quick at a total view for the patient by using the PHE. Because of the time, I will skip a couple of sheets right now, because this is going more into the development of standards, and maybe that's less interesting for now. This one I will show. We work in Holland with generic building blocks when using the standards, and that's because those blocks can be used in different standards. And that's how we try to provide, to give a data model for the new healthcare system. So cross domains, you can change the same kind of information that's based on these blocks. So people know what they send and what they can expect when somebody sends them their information. This one I will skip also. Again, the standards, we're so proud of it that this is already available for patients right now to look into. You see here the push and the pull. We have two kinds of ways the information can be collected, the pull kind of thing. And we have about 10 to 15 use cases that can pull information, and we have now 4 use cases that can push information towards the caregiver. So that's it. That's the one that will change the interaction also with the with the caregiver and the patient. Now, what's the current status of MedMij? There are about 48 prospective participants. Those are 25 PHE developers, suppliers, and the rest are suppliers that connect the caregiver systems to MedMij. We have an agreement system 1.3 published. One of the things that's now in there is subscribe and notify. So that's a very nice feature that you don't have to synchronize all the time your dossier in your PHE, but you get notifications that something has changed. We are developing new standards, data standards. Vaccination in this day and age is a very important one. We don't have that. That will be developed in 2021. There's new finance on the way, so it's more to sustain, to make the system more sustainable. We are very active in implementation of the agreement system and the standards. So, and we're still monitoring the go live. Well, all this is developed to make a basic structure, and we hope that the plant will grow and the new health kind of way, the new health system will flourish as a plant. There are, of course, challenges. I will go through this. Oh, that was a little bit quick. Yeah, the dream touches the practice. We see now that some things may not work in real life. Maybe a standard that isn't very aged yet to work. The user-friendly personal health environment is a challenge because of so many dossiers. You have so many different languages in the health system. People don't understand all the data. The change in the healthcare is, of course, a slow one. Caregivers, yeah, they need to change their state of mind, their processes to work with this concept. And of course, Corona didn't help. It takes us about a year extra to where we wanted to be. The year 2021, what will help it? Supporting live initiatives, monitoring the go live, see where it goes right, see where it's go wrong, learning, stimulus of the PHE use, a national campaign, what is it, how can you use it? And we, of course, continue develop products for the MedMij system. And that's it. So if there are any questions, please ask.
So thank you very much.
Thank you very much for your interesting and excellent at the same time presentation. I have a question. I don't have a question in the chat till now, but I have a question for you. You are talking more or less for a personal health record that can be used in order to have access to other healthcare professionals.
Yes.
Is this data saved in a personal place of the patient, of the person, or it is saved somewhere central together with all the others that they stay in this system? Do you have a portable personal health record, or do you have a central personal health record?
You have a personal health record. The person is, he can access the sources of the data, and he will get the information into his personal health environment, but he will decide which information he will keep or not keep. But he can always synchronize again with the sources if he thought he missed something. So there's no central database for all the data. It's all in personal place.
Thank you. Alexandros?
Yeah, I will skip my questions and leave it for the end so that if we have more time. One interesting thing that we need to keep in mind is always the legal part of all this. So I don't think technology is the issue. So for me, information on how you solve that equation will be necessary. Maybe we can put some comments in the chat about that so that we don't spend time on this issue. From a previous session that we had, that was the main point of discussion. So technology is here. It's here for many years, standards as well. Usually it's the organizational and legal part that needs quite a lot of reworking.
Yeah.
I think we should move to our next speaker, Dimitris. I can introduce, if you want, Ms. Catherine Bugmann from eHealth Swiss. eHealth Swiss is the program operator of the electronic patient dossier in Switzerland. So we are keen, Catherine, to have more information from your side and how you put the mobile health component on top of it. Thank you very much.
Yeah, thank you very much. I will share also my presentation. Can you see it? Okay, very good. So thank you for the opportunity to present the work that we did around the electronic health record in Switzerland and mHEALTH. So before I start with my presentations, I would like just to say some few words about eHealth Swiss, because this helps you to understand why we did proceed as we done. So we were founded in 2008 from the Federation and the 26 cantons. So in Switzerland, you have 26 regions. And it's important to know that for the health sectors, the cantons are actually, the 26 regions are responsible for it. So if you want to implement a nationwide IT project like the EHR that we are implementing this next year, you have actually to take care of 26 health laws, 26 data protection laws. So it's quite a complicated thing, and that's why eHealth Swiss was founded to actually coordinate all the work over these implementations of the EHR. So as I said, we are implementing an electronic health record, and for this we published in 2007 the eHealth strategy, and the EHR is actually the heart of this strategy. And it aims actually to make data around the treatment accessible for all the health professionals that are involved in the treatment of the patients. So you will find in your personal EHR like documents like the medical list or the X-ray findings, or also the discharge report, for example. And all these documents or informations are created and also uploaded by the health professionals. But patients would also like to share documents and information that they collect themselves with the health professionals through the EHR. So we actually written an article in the federal law on the electronic health record that makes this possible on the legislative side. But we also wanted to enable them not just to upload information through their computer, but also through mobile devices. So therefore, we written the article in the law firstly, but we wanted, as I said, it's just one side of the story. We wanted also to assure that the conditions to enable this were here, that they were in place. So we created a working group with experts and looked actually on 5 topics or themes around the mHealth field. This was regulations of medical devices, data protections and security, reimbursement, interoperability, and empowerment of professional mHealth users. And as we started the discussions in this working group, we actually saw with experts that the legislation was so far given, it was okay. There was no need to make new law, but there was a lack of transparency. So we worked very hardly on recommendations that we are now making in place. I would like to present the work that we've done around these recommendations. And for that, I would like to highlight 3 of these 5 topics. This is regulations of medical devices, interoperability, and empowerment of potentials mHealth users. So now to start with the regulations of the medical devices, there we saw actually that some of the app developers didn't know that their product actually was a medical device and should go through the certifications process. So we elaborated to help them actually a guide, a practical assistance, so they could easily make the difference if the product was a lifestyle product or a medical device that had to go through the certification process. And the guide also helps them or guides them through the certifications process, and is also goes also with a checklist. So this guide or this practical assistance was published and is also available in English if you are interested to have a look in it. Then for interoperability, as I said, we want that patients can share data with the health professionals through mobile devices. And there's, of course, the challenge that they will use different mobile devices to share data through the EHR with their health professionals. So for us, it was very important to assure interoperability. So the first thing we did was we elaborated a report with recommendations for the use of technical standards and norms in the mHealth field. And all these standards are also used internationally, so in other countries. So we really looked that there were international standards, actually. On basis of this work, we did a rough concept for connecting mobile devices to the EHR, and then we adjusted IHE profiles to assure that the apps could be connected to the EHR. And we tested actually the EHR profiles this year in our PREREQUISITES. This is a testing event around the EHR. And the next step is that we would like to adopt and implement these profiles into the EHR regulations. Then we also would like to create more transparency for the app users, because there are really a lot of apps for the health sector. And it's quite difficult for the users to find transparent product information. So if you use an app, often you ask yourself, where's the data stored? Who owns the data? When I use this app, are the measurements reliable? So we decided also here to create a list of criteria, actually self-declarations that could be filled out by the app developers, so that the app users have the information that they need to decide if an app is good for the purpose that they want to use it or not. So we focused actually on the work of 9 generic criteria, with the idea that all the users of this self-declaration can find the information that they need. So if, for example, an oncologist would like to recommend an app to a patient, that he could look on this web platform where the self-declarations will be published, and find the information that he needs, and be sure that the app that he is recommending is okay for his patients. So the idea would also be that if, for example, a health professional association would like to recommend apps for the target group, that they could look at the informations on this web platform, decide if they want to recommend the app, perhaps also test it, and then give the label to this app, the recommendation label to this app also on this web platform, so that the patients also could see that it's recommended, so that the patients and the health professionals could see that it would be recommended by this health professional association. So the next steps now are to develop a first mock-up for next year of this web platform, also with the relevant stakeholders, so that we are sure that their needs, that we can take account of their needs, and to implement then this final platform in 2022. So our main aim is actually to create around the EHR an interoperable environment, so that the EHR, of course, is interoperable, but also all the mHealth services around it, but also the additional interoperable services like B2B or B2C services around the EHR. So this is what my presentation contains. If I can answer your questions, if there are any, I would really gladly do this.
Thank you very much for explaining us in a few words what is the status in your country.
You're welcome.
Maybe we can accept one question, Dimitris. Do you have any questions or any comments from your side?
I just want to comment that this is the best way to ensure the quality of the services and the acceptance of both parties in use. That's a really good paradigm of how to use technology and to spread the technology results among all the persons in a society. Thank you very much for your presentation.
Thank you.
Okay, so I guess we can move to the next presentation then. Coming from Germany, we have Jorg Trinkwalter. I hope I made it correctly. Will explain us in a few words on the new law about these reimbursements of digital therapeutics, this new German Digital Healthcare Act. The floor is yours. Thank you.
Thanks for the kind introduction. Good afternoon, everybody. So my name is Jorg Trinkwalter. I'm coming from an organization called Medical Valley. In general, we are an innovation ecosystem management organization here in Bavaria. And we are one of the leading digital health ecosystems here in Germany. We've been awarded by the Federal Ministry of Education and Research as so-called National Digital Health Hub. And that's why we have a very close relationship to the topic of digital health. So the Digital Care Act I would like to introduce to you was implemented in December 2019 by the federal government. And the operative start of this Digital Care Act was at least in May, June 2020. So I think the driving force behind this Digital Care Act was, the effects of digitalization, or to be more specific, it was the vision that digitalization will lead to a patient-centered healthcare system. And I think this is one thing we could see also from the COVID pandemic, so that we see, at least here in Germany, kind of an accelerated implementation of digital medicine. So perhaps these are some of the very rare positive sides of COVID. Yeah. Just to mention some examples, we see an increased usage of digital tools here, corona tracking apps, video teleconsulting. We see a change in public awareness. For instance, in the discussion, personal medical benefit versus data risks, we see also new technological solutions for privacy and digital sovereignty upcoming. So a very strong effect. And this is, let's say, one of the backbones here in Germany is this new Digital Care Act. And one of the main things of this Digital Care Act is that you can prescribe apps as a doctor. So it means in the past you could prescribe drugs and remedy aids as a medical doctor, and now you're allowed to prescribe apps. And I think let's say the most decisive information about this is that these apps are then fully reimbursed by the public payers. And this is really a game changer, when it comes to digital therapeutics, for instance. So what you can see here is a Parkinson medication system. It's one example from our ecosystem. So a startup company which develops a sensor which is inserted into a shoe, and with this shoe they can make gait analysis, and based on this gait analysis they can structure the whole medication and home monitoring process of Parkinson patients. So it's really a nice thing. In the past, you could say really a nice app, really a nice application and service. But where's the market for this? And this is exactly what this Digital Care Act is changing dramatically here in Germany. Because now it's so, and this is, let's say, these are the cornerstones of this Digital Care Act. So if you are a medical device of a low risk class, according to MDR or MDD, class 1 or class 2A, if your main function is based on digital technologies, so it has a digital main function, and this is really a decisive point, if you are a patient-centered application, so we talk about patient-centered systems, and if your app is supporting recognition, monitoring, treatment, alleviation or compensation of diseases, injuries, or disabilities, then you're able to bring your solution into the German reimbursement system. So the general requirements of your app are: you have to show a technical functionality, you have to show technical quality, technical safety. All these things you have to put together into an proposal which you submit to the BfArM. The BfArM is the national the national authority for medical devices and pharmaceutical products. And if they say, okay, you have everything in place, then you have to. Then they will give you the approval for stepping into a so-called fast-track period. And within this fast-track period, you can or doctors can already prescribe your solution, and you will already get a reimbursement for 12 months. And within this 12 months, it's kind of a clinical study. And within this 12 months, you have to show the evidence for your positive healthcare effects with your app. And positive healthcare effects means in general medical benefits, as well as patient-relevant improvements of structures and processes. So again, like I've already explained, you have this, you fulfill the preconditions of this law, then you are able to step into this 12 months trial, fast-track procedure. And within this fast-track procedure, you are already allowed to address 73 million publicly insured people here in Germany. And this is really one of the, let's say, most interesting and biggest digital health markets in the world. So what kind of DiGAs? So that's a German word, yeah? Digital health applications, the German word is DiGAs. We see different types of DiGAs upcoming, yeah? So DiGAs are interventions, yeah? So they have to lead to a positive healthcare effect, like already mentioned. We see purely interventional DiGAs, means patient-only use. So DiGAs which supports the intervention, typically aiming at medical benefits, or DiGAs which records information, but this information is not fed into the healthcare process. We see management DiGAs, so with tailored information delivery, or we see mixed DiGAs, which have a diagnostic function, wearables included, like the Parkinson example I showed you some slides before. So again, the process, just to understand it, so you have to have a DiGA-ready app. You have to have a study protocol. You're writing a proposal to the national authority. They will approve your proposal in a maximum of 3 months, and then you can go into this fast track period, 12 months. So you have to do the patient recruitment. You have to track your interventions, and you have to do a scientific evaluation. But during this period, you already get a reimbursement. And after this, you will you will step into negotiations with the public payers organization here in Germany in order to negotiate your final and sustainable reimbursement of your solution. So a lot of things you have to do. One offering I can make you. So we as a Medical Valley organization, we co-founded a so-called digital health CRO, clinical research organization called DMAG, together with Fraunhofer. And with this Fraunhofer, we can support you alongside this way. If you are interested in DiGA solutions, or in solutions which are already approved DiGA, you can find them on diga.bfarm.de. There's kind of a register, and in this register you see all approved DiGA so far. For instance, here's one example. It's a therapy against phobias. So thank you very much for your attention, and I'm happy to answer your questions. Thank you very much.
Hello. So that's, let's say, a way to create a market, if I understand well. You are creating a market.
Right. Yeah. Now you have a market. You can create a stable business model. And this, let's say, has consequences. If you have a startup and you have to go to an VC investor, for instance, and convince them that your telemedical solution is the best way to go for, but you do not have kind of a strong business model, then it's a bad situation. And with this Digital Care Act, we see, let's say, we have a foundation for business models in digital health, and this is what it makes, let's say, very attractive.
Tell me something. As I understand it, you don't have the idea of providing the best applications, the best, and pay for them, but you just create a market that could help innovation and could help people and small societies and small companies to provide applications that probably they will do it more fast than bigger companies, and you will arrive in 1, 2, or 3 years in a well-defined paradigms and applications that they have proven their results. So more or less is, let's say, a beginning. It's not the arrival, it's the beginning.
It's the beginning.
You are the first in European Union, as I understand.
Yeah, so I think we are the first nation. Let's say, so Germany was not a front runner in the past when it comes to digital health. Yeah, so we've been not very in a front position, but now let's say the federal government is trying to push digital health forward and to digitalize the German healthcare system. And let's say this was the first law which what the federal government implemented. According to this law, we do also have a future hospital law, which means this law or this act is mainly tackling the outpatient sector with the apps. And with the future hospital law, it's also in place since September. They are now tackling the inpatient sector, and there's a new law currently in discussions in the national parliament, which is dealing with all the transsectoral things between outpatient and inpatient sector. So I think we are now really on track. And let's say, coming back to your first question, don't underestimate these solutions. They have now the chance to show their or they have now to prove their evidence, yeah, within this fast track period, and they have to show this positive healthcare effects with studies. If they do not show this kind of positive healthcare effects, then they will not longer be reimbursed. So I think this is really a smart way to do it. And these kind of studies are very, very, they are very, very comprehensive and holistic.
Thank you very much. Thank you for your excellent presentation. Alexander, do you want to add something?
No, I'm personally impressed by this German leapfrog that happened in 1 year times. And so we are now the example to the other European countries. That's a very good point, I think. And I hope that the Greek government will be inspired by your, let's say, good moves, and hoping that we merge all the country markets into a bigger one, a European one, hoping that could be a next step in that approach. So I would like to thank you very much. Just to remember that the audience can always use the chat to send additional comments or questions if they want. Let's proceed to the next presentation. It's a pre-recorded one coming from a European project that experienced the use of such mobile applications in the domain of diabetes. Can we ask the organizers to present this presentation made by Ozan Beyhan and Strahil Birov from the ProEmpower project?
Good afternoon and welcome to our presentation focusing on mHEALTH telecare for patients with diabetes mellitus, the ProEmpower experience. My name is Strahil Birov. I'm a research consultant at Empirica Technology Research in Bonn, Germany, and I'm joined today by my colleague, Ozan.
Good afternoon. This is Ozan Beyhan from Ministry of Health of Turkey. I'm a project consultant at General Directorate of Health Information Systems, the unit which coordinated ProEmpower project on behalf of the ministry.
We cannot, as you can see, we cannot be present. This is a recording, so we're talking to you from the past. A week ago, we took this recording, so there will not be possibilities to answer questions directly, but feel free to go to the website that you can see here, proempower-pcp.eu, where you can see more information about the project and also get into contact with us. So we're very happy that we can join you virtually via recording today, and we'd like to present to you our experiences related to telemedicine and telecare, which we've collected over the last several years. We will go through some background about the ProEmpower project in the context of the diabetes solutions that were developed within the project. We'll briefly also present the two solutions that were fully developed and tested, as well as the results of those tests and pilots. Ozan himself, as a procurer, will be able to share some experiences, and we also have the experience of another procurer which is not present, and we'll conclude hopefully within about 15 minutes. So with that, I give the word to Ozan.
Thank you, Strahil. Thank you also very much for making room for us today, and many thanks to the organizers as well as Alexander Berler from Gnomon for the kind invitation. Next slide, please, Strahil. Today, as my colleague Strahil said, we would like to present you our project ProEmpower, the full title of which is Pre-Commercial Procurement of Innovative ICT for Patient Empowerment and Self-Management for Patients with Type 2 Diabetes. We started the project in October 2016 and completed it in September 2020 after a 48-month project duration. It's a PCP, a pre-commercial procurement project funded by the European Commission's Horizon 2020 program. It has a budget of 4,280,000 euros, 3 million of which was the procurement budget. In ProEmpower, we were 11 partners from 6 countries, and 4 of these partners were the procurers of the project. The project was also supported by an external advisory board. The region of the procurers in the project are inhabited by a big population, of which over 12 million have diabetes. Next slide, please. What is in the focus of ProEmpower is the chronic disease of diabetes, as our motivation was the fact that the procurers' care systems are facing an increasing prevalence of diabetes. The disease is expected to grow globally from 8.8% in 2015 to 10.4% in 2040 if no effective countermeasures are put in place. Furthermore, diabetes is seen more and more in younger years, but also it's increasing among older population, with the age group 80 and higher seeing a strong onset of diabetes. Next slide, please. The costs associated with diabetes include increased use of healthcare services, loss of productivity and disability, and consequently diabetes causes a large economic burden on individuals and families, and on a much larger scale, national health systems and countries. These are among the many common problems faced by the buyers group of the project. Next slide, please. We therefore came up with this project ProEmpower in order to initiate an investment up to 3 million euros in R&D procurement of a personalized diabetes management solution to support patients with type 2 diabetes. In the buyers group, we are 4 countries from the Mediterranean region mainly, where the prevalence and incidence of diabetes is quite high, namely Ministry of Health of Turkey, Shared Services of Ministry of Health of Portugal, Murcia Health Services from Spain, and Campania region of Italy. Next slide, please. We addressed several unmet needs in ProEmpower, from the fact that healthcare systems in the world are reactive and fragmented, to the fact that patients are lacking ownership, and also current treatment of diabetes patients are proving to be rather ineffective. And there are several other key challenge areas where we thought there were room for development, such as all the green tiles you see in the projection. Next slide, please. ProEmpower was an innovation procurement project, and the tool we used is pre-commercial procurement, shortly known as PCP. In PCP projects, the procurers, in our case healthcare providers, invest in R&D activities for products and services which are not available in the market yet and which address their unmet needs. Then, once procured for R&D, selected suppliers develop solutions called for through an open call and followed by competitive phases of R&D, which are solution design, prototype development, and pilot testing, which all occur in consecutive phases you see on the screen. Phase 1 is solution design, phase 2 is prototype development, and phase 3 is the pilot phase when the developed systems are tested in real-life conditions. Next slide, please. In our PCP project, ProEmpower, we published a worldwide call for tenders for innovation procurement, which was launched in January 2018, seeking innovative approaches to diabetes care and management. 15 offers were submitted to the call, 4 by single entities and 11 as joint tenders, also known as consortia of suppliers, and 13 of these offers were led by SMEs. Next slide, please. In 3 competitive phases, the best solutions were selected, leading to the full development and testing in real conditions of the 2 solutions led by SMEs from Greece and Italy. On the projection, you see the 5 solutions or solution providers who were selected to take part in phase 1 of the project, prototype development. After the competitive phases of 1 and 2, phase 3 was concluded with 2 solutions, namely DiaWatch, developed by a consortium led by Take4Care from Italy, and DM4All, developed by a consortium led by Gnomon from Greece. Next slide, please. Yeah, now I leave the floor to my colleague Strahil for a more detailed description of these solutions. Thank you, Strahil.
Thank you, Ozan. Well, I'll be very brief because obviously these are not solutions developed by us, but DM4All, as Ozan mentioned, is developed by a consortium led by Gnomon Informatics from Greece and with several other partners from across Europe. And what DM4All is offering is a full solution and a service that comprises different components. So you see them here: drug-to-drug interaction, educational platform, clinical decision support system. There are both interfaces for patients and for the healthcare professionals responsible for their treatment and care. There are different wearable devices and medical devices that are involved in the solution, allowing for a seamless flow of data and availability of this data to both stakeholders, allowing them also to discuss the results and agree on goals through a shared care plan. The diabetes monitoring for the professionals has the aims to increase the efficiency of the healthcare professionals, to provide them with predictive, proactive analytics that help them make informed decisions, improve collaboration also between the healthcare professionals, nurses, and specialists. It allows for remote communication and monitoring and clinical decision support, whereas the patients, they would receive the solution in the form of an application on their smartphone where they have the shared care plan, which allows for agreeing goals with their healthcare professionals. It has different community aspects and training aspects, which empower the patients to continuously monitor their diabetes and react on changes. So obviously the solution is very complicated, and these are just the overviews for DM4All. Similarly, DiaWatch has a similar approach where they have different components, a sensing system platform that you can see here, as well as applications and interfaces for the patients and healthcare professionals. Again, they're also using different devices, and the overall idea is that the system, the ICT system, supports the full process of diabetes management of the 4 procurers in the project. For more information, you can also see for each of them at the bottom their own websites with even more information. So let's talk a bit about the pilots, because as Ozan said, over the course of 3 different phases, which is, I believe, more than 2 years, these tools have been developed, tested with end users in prototypes, and finally also piloted in real life conditions. So the piloting happened in the phase, the PCP phase number 3 that you can see here. And how it happened is that for each solution, because we had 2 solutions and 4 pilot sites, each solution was tested by the pilot site with 50 patients. So one pilot site with 50 patients for DM4O, 50 for DiaWatch, 100, and then this for all the 4 procurers. So in total, we had 400 patients and about 82 healthcare professionals involved. You can see the periods of piloting here. They differ a bit from pilot site to pilot site, but in total, we aimed to have at least 8 months of piloting per pilot site. And you can see also in red the fact that during the middle of the piloting phase, actually the COVID-19 pandemic happened, and there were also lockdowns and other measures which obviously influenced a bit the results. But I guess that was also a challenge for the systems. That's the idea behind it, with remote and telemonitoring, that they are able to cope in these kinds of situations. And we'll see later on that this indeed happened. And the solutions were appreciated by both the patients and the healthcare professionals. So during this piloting, we monitored different evaluation indicators, different parameters before and after the pilot site duration. The glycemic control, HbA1c, blood pressure, body weight were some clinical data that we monitored, but we also collected non-clinical data such as quality of life, physical activity, usability and satisfaction of the service, etc. They are quite comprehensive data that will be published on the website very soon. We expect this to happen in the beginning of next year, but here already we can share some of them with you, the most interesting ones, starting with glycemic control. Looking at the pilot data, again, we had 8 different pilot sites, 2 solutions and 4 pilot sites. So we can see that the HbA1c values significantly dropped for 5 out of the 8 pilot sites. You can see also the differences here for Turkey, Portugal, Italy, and the Spanish pilot site per solution. If we only look at participants whose baseline values were higher than 7%, so they were poorly managed to start with, the difference is even bigger, and the significance also applies to 6 out of 8 trials. However, we didn't want to focus only on poorly managed patients, because this is the process of the R&D, so we have to be open to ideas and see whether the solution works as well also for all kinds of groups, to be able to narrow it down. Also, systolic blood pressure, you can see some data here. There were significant reductions in systolic blood pressure in all of the trials, and this is also a positive outcome, a clinical outcome. In terms of usability, satisfaction, and usefulness, we asked the participating patients and healthcare professionals what they thought about the solutions. So different parameters such as experience with the solution, satisfaction, ability to get along with diabetes using the solution, whether it was worth the effort involved, overall usability. And you can see here that overall both solutions scored quite high, or rated quite positive, with some small differences between them, but overall both solutions were welcomed, and in terms of usability we see some high results in both groups. To summarize the pilot outcomes, we observed reduction in HbA1c values and systolic blood pressure values. There was slight improvements in patients' perception of their disease. The piloting period is 8 months, so obviously if we have more time and data, we might have also more conclusive results. What we focused on in the project was we set up a technology trial. It wasn't a clinical trial, so we didn't have, for example, a control group. But going forward, we believe that these are very promising results, and probably with a follow-up clinical trial, they can be also confirmed. And yeah, that would be the summary of the results. So Ozan, I give back to you to just report on your side, you as a procurer, as a healthcare provider, your experience with using the 2 solutions.
Thank you, Strahil. Now I would like to briefly present you with our experience in ProEmpower project, more specifically what we experienced in the pilot and the lessons we learned. We carried out ProEmpower pilot in Ümraniye, Research and Training Hospital in Istanbul. The pilot was carried out in internal diseases clinic with a team of 10 researchers. The pilot started in July 2019 and ended in July 2020, but this 13-month period is the duration of the two solutions with different time spans, who both achieved at least an 8-month piloting. 100 patients with previously diagnosed diabetes type 2 were followed, 50 for each solution. And one of the things we paid attention while enrolling the patients was technology literacy or technology friendliness, so that there would not be any or not a lot of resistance to use novel technologies. Next slide, please. This is our team. In the picture, you see some of them. The ProEmpower pilot team was led by Dr. Sema Basat, who is the clinic chief of internal diseases, who is an internist and who is also a professor who lectures in the training hospital. We had 2 other internists and professors in the team, 1 other internist for assistant specialist, 1 registered nurse, and 1 registered dietitian. One of these assistant specialists, Dr. Gizem Najak, completed her internal medicine thesis on ProEmpower, and she's an internist now. It is also my pleasure to say that our team consisted of 7 female researchers and 3 male researchers. The majority of the team was female researchers, led by a female lead researcher. Next slide, please. We learned many lessons from ProEmpower, but because of time limits, allow me to focus on some key ones, some key lessons. During the remote follow-up of patients, technical problems were frequent. The team needed continuous technical support, and this showed us the importance of a help desk. Good thing is we had already thought about this, and this challenge was addressed with the provision of a help desk. Healthcare professionals needed extra time to use the systems. There may be nothing surprising about this, but the lesson we learned for the future is that we should prepare a good change management strategy, a change management that will be welcomed by the healthcare professionals in terms of time management and payment. Patients' follow-up, treatment, and prescriptions were supported remotely, which showed us that e-health technologies are a great means to close gaps. By gaps, I mean both the deficiencies of the healthcare system and also the physical gaps between the doctor and the patient. Most of the patients were happy to be in this practice. Metabolic control was not impaired throughout the pilot, even in times of the pandemic, thanks to the shared care plan between the doctor and the patient and the continuous monitoring without the patient having to come to the clinic for regular visits. Another important lesson is that none of our ProEmpower patients caught COVID-19. This may not be a scientific indicator. There may be other dynamics behind this, but still, one of the reasons we thought was the fact that our ProEmpower patients did not have to go to the polyclinic examinations during the pandemic, as they were already in touch with their doctors on their applications. Next slide, please. And ProEmpower and its objectives are perfectly in line with the ministry's objectives. We have a strategic plan published every 4 or 5 years that defines our midterm roadmap. The current strategic plan defines development and procurement of applications for monitoring and managing chronic diseases by 2023. In order to achieve this goal, we already procured a doctor interface for what we call chronic disease management system. The system of Turkey entered into practice last year as a pilot operation and were tested in 4 cities. The system provides the family physicians with a decision support system, which warns the doctor who they will examine when and in what intervals. The decision support system does this thanks to its ability to analyze the patient's health records and family history. Then the doctor contacts the patient and calls them over to the primary clinic for regular checks. The disease covered are diabetes, hypertension, cardiovascular diseases, chronic kidney failure, stroke, and geriatric diseases. Although the system is technically ready to be used as a countrywide operation, the large-scale rollout is on hold due to legislative framework, in particular due to pending updates on the regulation of the payment systems to the doctors. The system currently does not have an interface for the patient, therefore it doesn't come with a shared care plan, but it is the midterm plan of Ministry of Health of Turkey to integrate a patient interface into e-Nabız, the personal health record system of Turkey, and connect the patient and their doctor on a shared care plan, where a ProEmpower solution will be required to cover a gap is here. So what will be done in the upcoming years is the procurement of a shared care plan. Next slide, please.
Thank you, Ozan. Another example we wanted to give was just another procurer, our colleagues from Murcia in Spain, who also participated with 2 different pilot sites that you can see here. One pilot site was one healthcare center, which focused on 50 patients and DM4O, and another one that focused on the solution DiaWatch being tested. So they also had quite the team of physicians and nurses, in total more than 30 professionals participating. They had also some interesting lessons learned. One of them is it's not about blood test, it is about lifestyle. So they approached this a bit more general because they saw that the benefits from DiaWatch and DM4O are not just for patients with diabetes, but the underlying risk factors such as being overweight are also part of the lifestyle, and that's why these kinds of solutions such as DM4O and DiaWatch, which involve wearables and constant feedback, allow for many different things to happen, not just for your diabetes to be managed, but also physical activity, diet, etc. So they also recognize the importance of change management, and automatic recording, which is made possible only because both solutions were integrated with the existing systems of the procurers. And they showed also that it was good that the tool was present and available during the COVID-19 period. And some examples here of positive outcomes of patients and professionals. You know, they saw people that have been empowered and their motivation has been raised. They also saw patients who do not require insulin anymore, which is a great success, and people who were just, staying fit, which is, again, beyond diabetes. It could be, the solutions could be applicable also to other areas, disease areas and conditions. Similarly, also the healthcare professionals found the solutions useful and appreciated that their workload is more efficient thanks to avoiding unnecessary visits, especially during the pandemic, which was not possible to happen. So, just to conclude, I will start. We think that the concept of pre-commercial procurement, which is rather new, it is being done on an international level, but
it was a nice presentation about hands-on
their systems. Ozan, do you want to add anything?
No, Stryle, I think you covered this perfectly. Thank you.
Then we'd like to thank you for your attention. We hope that you have a productive remaining rest of the meeting and the workshop. And yes, Ozan.
Yep, thank you once again. And I also wish all the participants, speakers, moderators, and organizers a good conference. Thank you so much.
Alexander, back to you.
So I think we just experienced a very nice 2 years experience on diabetes. It was with 2 solutions. So a good experience of how this could be done, and especially maybe a good idea on how to explore this type of information of systems to be added in, let's say, national strategy, especially the idea of using the pre-commercial procurement to procure innovative solutions. So without any delay, I think Dimitris will have to pass to the last presentation of today, and I would kindly ask Mrs. Crystal Dennis to start her presentation about what happens in the UK and Dorset.
Good afternoon, everybody. Can you all see my screen?
Yes.
Fantastic, thank you. Thank you. Full screen here. Is that better? Thank you. So my name is Crystal Dennis. I'm coming to you from Dorset in the south of the United Kingdom. My role here is to lead the public-facing digital health technology agenda. And so I'm going to talk to you about how we're approaching it here in Dorset with our population, and how we're approaching it with the financial and the workforce limitations that we currently face. On your screen at the moment, you will see that these are the barriers that we're coming up with digital innovation and transformation. So very much around our workforce and our population being made aware of what they can access, how to access digital health technologies, helping the workforce and the population trust what is available to them, and making sure that this is done in a coordinated way. So I just want to reinforce that even though I'm here to talk to you about digital or mobile health, that actually the agenda here in Dorset is very much around all of our digital programs working together in a system approach. So each will have its own benefits and its own outputs, but it's only by working together that we are going to collectively achieve the cultural transformation, both in behaviours and in the digital investment and with our workforce in order to achieve the health outcomes and deal with some of the problems that we have. So we have something, a programme or a theme around infrastructure and our enabling technologies, very much around our bandwidth and our cyber security and our data protection. And then we also have our interoperability piece, which is just down here at the bottom. This is very much around our shared cared records and making sure that the hundreds of systems that we have actually talk to one another. And then we also have the use of our business intelligence for secondary use, so our population health analytics. This is where we've joined together our general practice data, so our primary care data, our community mental health, and our acute data in order to understand our population and their behaviours a little bit better. And it powers our population health insights. And then, of course, there's the programme that I lead around digital health. None of this can be done without full working with our workforce systems around digital readiness, with our population around their digital literacy skills so that we're not leaving anybody behind, and research plays a huge part into this agenda. So in the themes that you can see here, there are 2 very clear processes. One is around efficiency, and that's how our workforce work. And one is around culture change and the transformation piece that often gets missed when we're looking at things from a digital project management piece. So the problem that I'm trying to solve here in Dorset with our team is around our population health analytics and re-establishing the way that our population interacts with our health and social care system. So it's taking a personalised approach, using a digital first approach where appropriate, and using the technology to act as an elastic band around our health and care teams. So I know that regulations and the legal aspect tends to be an ongoing theme in all of these discussions. But actually what you can see here is that here in the UK, we've understood that not all digital health technologies are the same, and the regulations change according to the purpose of the technology. And we have 4 different levels of those here in Dorset. One of them is around prevention, and these are standalone applications or digital health technologies, things like step trackers, fitness trackers, diet apps. So they don't necessarily sit within our pathways. They're there for people to use as part of the prevention agenda. And we know that in the Android and App Store, there are nearly 400,000 digital health technologies or apps that a person could choose from, but less than 2% of them have actually been proven to be clinically assured. So we want to make sure that we are educating our workforce and our population around which ones are safe to use. And I'll talk about that a little bit more later. So we have apps that sit in the prevention agenda. Our second level is around integrated digital health technologies. So these might be some communication platforms, things like platforms that power your texting or your email or your video conferencing. It could also be things like symptom checkers or mood diaries. So these are ones that are kind of supported by the care team. They might be able to see the data that sits behind them or what the patient is contributing into those front-end platforms. We also have a third level, which is around pathway replacement. These are very much linked to things like mole checkers. They usually have some type of machine learning or AI that sits behind them. So mole checkers, blood pressure monitoring, ECG monitoring, things that you could use your device or use a device with a split level app that could feed back into your clinical teams. So very much around the remote monitoring agenda. And then we have our fourth level. These are quite heavily regulated. They're usually the personal health records, so they're administrative support. So they would visualize our clinical correspondence through to a patient, or they would allow a patient to book into their care setting, or electronic repeat prescriptions. So it's by using all of these together in the appropriate format and applying them in the right way that we end up making a change to the pathway. So those are our four areas that are regulated differently. And that's part of the knowledge exchange that we do with an awful lot of our clinical teams in the first instance. So whenever we are looking at digital health technologies, either in apps or wearables, we're very much looking at four themes in this regulatory puzzle that I just went through with you. There's very much a data privacy and security issue, clinical assurance, and user experience. And what we recognised is that every time we were going to be looking or recommending or signposting either a patient or a member of the public to one of these technologies, we wanted to make sure that there had been a full evaluation so that if it does require them to put their data into it, it was safe. And that it was clinically assured and still had a good user experience. No point in using a technology that has a good user experience but doesn't keep somebody's data safe. And so we needed to make sure that we worked with a partner that could do that in real time for us. For instance, one of the technologies that we use here around long-term condition management in Dorset has had 20 developer updates over the last 12 months. And so we use a partner that does the evaluation. They will pick up on the Android or App Store every time a developer does an update, and they will go in and they will evaluate the update or the change that has been made so that we are again always mitigating our implied liability or chain of indemnity for our clinicians in real time. So we're trying to mitigate that risk as best as possible. So in our digital health agenda, we realise there are building blocks. There is no one particular technology or platform that is going to deliver the vast amount of requirements. These requirements come from various clinical teams from various parts of the system. The stakeholders that use them would be different. And so we've accepted that we're going to need to be able to work with many industry partners and lots of different technologies. And it's actually the architecture that's going to bring that together. So the absolute foundation of our building blocks is around our digital health information. And that at the moment in Dorset is powered by 3 platforms. We have a health app library, we have a video library, and we also have NHS UK, previously known as NHS Choices, and that's regulated here by the NHS England and Improvements group. On top of that, we have our online triage. That's our eConsult platform powered by our industry partner eConsult, and that really allows somebody to complete an electronic form and make a request through to either their GP or their clinical workforce in primary care. And that could be returned either by a video consultation from the GP, they could make a response via an email, or they could make response by an SMS or a telephone. And of course, they would draw down from the platforms in terms of signposting and education patients for self-management from the building blocks with our app library, video library, or NHS UK. Sitting on top of that, mainly done by our nursing and our advanced nurse practitioners, is around our long-term condition management. And we were looking at COPD, asthma, heart failure, and diabetes. And they're very different, those platforms. They are there around accelerated access through to things like pulmonary rehab or cardiac rehab, being able to assess and view a patient's trend analysis of the data that they are putting into those portals on a regular basis, in order to be educated at any time of the day, whenever they feel that they need to, without worrying about making an appointment with their clinical team, and then being able to manage their care and coordination. So we look at these around patient-initiated follow-ups. So these are types of technologies that, even though there is a clinical portal that sits behind those front-end apps, that allows the clinical teams to be able to caseload or to see all of that patient-contributed data, but there is no expectations for them to be doing remote monitoring of the patients that use those. If they choose to do caseload management, they can do, but in this developing piece of digital health at the moment, some of the teams just aren't ready. So we look at those types of population in two different categories. One of them is around the rising risk of the population, and one of them is around the highest risk of the population. And according to the way that they take care of themselves, their age, their wider determinants of health, they might go in and out of those groups. So that's our long-term condition management. And then we've heard a lot around personal health records today. So again, those are like those administrative platforms, regulations. So we have one here in Dorset, and it's like a digital passport. So it means that the patient can take an electronic form of all of their contributed data and clinical correspondence with them to anywhere that they are in the world or in the UK. They can contribute to that, and it will be fed back into our summary care record or our clinical portal that sits behind that. And actually, it's the personal health record and their team that architecturally are responsible for bringing all of those patient portals into one area, so that they can have a single point of navigation for the population. And then we move more into the area of remote monitoring. So these are digital health diagnostics, things like pulse oximeters, blood pressure monitors, and screening tools like urinary analysis being done from home. So these platforms are medical device regulated softwares that truly allow a visualization of all of the patient contributed data in a RAG rated, so that you can have a true virtual clinic. And we are using those types of platforms at the moment for COVID monitoring of patients at home, so that we can identify deterioration of them earlier wherever they may be in a community or home setting. And of course, there is a lot of data mining that sits on top of that with artificial research and machine learning. So that's how we categorise the different types of technologies here in Dorset and how we apply them within the care model. So whenever we're looking at a platform, we will take a population health approach using the analytics that we have available to us, and we will look to develop those further in each one of our projects. And of course, that sits within a separate part of our digital transformation programmes. That's around our business intelligence. And so all of the data that I use from these technologies is fed back into those platforms, so that we can get more of an understanding of the digital behaviours of our population, and also ensure that we're not increasing health inequalities, we're not widening the gap or access through to services. So this is what it looks like at the moment. We have long-term condition management portals around diabetes, asthma, COPD, and heart failure. And the reason why we have chosen that is because with a population health approach, we know that if you develop one, you can develop more than one of those conditions. And we're not going to be asking patients at the moment. We do not have the technical architecture, enterprise architecture or design to bring different platforms together with the same user experience. That's an ongoing piece of work. And so we work at the moment with one provider that covers all of those conditions. We are working with another provider that specialises in oncology and the risk stratification of patients with cancer, particularly breast and colorectal, so lower GI and upper GI cancers. And then we also have a maternity portal for those that are going through their pregnancy. So again, these are all areas where we have a shortage, particularly in our cancer teams. We have a shortage of specialist consultants. And so it's a way of us being able to manage the population and get them access through to the correct services. So we use a different way of utilising the workforce that all have access to the patient contributed data that sits behind these portals. On the left-hand side here, you've got the digital health information. That's the absolute building blocks. And this is what our video library and our app library looks like. And then we've got some of the projects that we're looking at from the diagnostics or the remote monitoring from home. So you can see a blood pressure cuff and a pulse oximeter there. We also have, for our diabetes pathway, a urinary analysis screening tool, which is around our ACR. So these are a type of protein that is searched for in the urine. The population with diabetes do need to have an ACR check on a yearly basis to help identify if the patient's moving into chronic kidney failure. And actually, as a system, it's one of the checks that doesn't always happen. Just purely because either patients don't have time to do it or they haven't dropped their samples back into surgery. And of course, statistically, what happens with that cohort of patients is that they end up moving through the 5 stages of degenerative kidney disease. And at stage 3, they will end up mostly being conveyed in a crisis form or for an inpatient stay because they haven't been on the correct medication because it hasn't been identified. So we're looking at increasing compliance to the NICE guidelines by making sure that those checks are done on an annual basis. And we're actually looking at the application of those checks within our hypertensive population at the same time. So in the centre there, you've got our personal health record that is tethered or linked through to our summary care record in Dorset. It's called the My Dorset Care Record, and it is architecturally responsible for bringing together all of those digital health platforms into one user experience. This is how it looks like from a care model perspective. So patients that are looking to gain access through to their clinical teams would complete an online triage, an online e-form, either through the NHS app that's been made available to us by our national teams or through the practice website. It goes through the administrative workflow. A clinician will review that within 24 to 48 hours. They will either then online message to the patient via an email, they will do a video consultation, a telephone consultation face-to-face, or send a text, and they will signpost either using one of the platforms for education in a supported self-management way. On the right-hand side, you've got some of the branding of the platforms that we use here in Dorset. And then if a patient is or does have a long-term condition, again, we will use a digital health coordinator in order to review that virtual clinic data and will escalate appropriately through to a nurse or through to a doctor, dependent on the risk of the patient. So some of the things that we have noticed around our workforce when we've been looking at developing this agenda is that we needed to have a community of practice in order to keep the chain of communication between what was happening centrally and how it was being applied. So we have developed that, and we have regular webinars with those groups. They could be GPs with specialist interests, consultants, nurses, healthcare assistants, or even admin coordinators that take on or in an apprenticeship. And again, we're trying to repurpose any releasing capacity to the workforce in order to provide better care for those that are at the highest risk of the population. And for those where administrative purposes are being streamlined, there's the offer of apprenticeships going forward. We have clinical implementation groups, and again, those are different dependent on the subject that we're dealing with or the project at hand. We also have brought all of our patient portal groups together. So cancer, the long-term condition management, hypertension, COVID at home, they all come because they'll all come come up against the same challenges. And we're developing our workforce by realising that a care coordinator should be a digital health coordinator or advisor, because the onboarding of these technologies and the constant iteration of the use of them does need to be done at light touch, doesn't necessarily need heavy clinical involvement. It's more about moderating it and keeping it in regular use. And that can be through a reward or through a nudge to the patient, either using the portal or through an SMS text message. And of course, in digital in general, we have to break down the barriers around awareness and accessibility and trust. And by helping those barriers be broken down, we've made available fellowships, digital fellowships, multiple ones for any part of the clinical team or operational teams, because you build that type of experience over time. We're also making good use of our clinical safety officers, because the hazards of all of these clinical hazards of these coming together is becoming more complex because of the dependencies between all of the technologies and the use of those, both for either research or for secondary use in our population health analytics or for decisions at point of care. And so we've had to invest time and money into clinical safety officers, making sure that we have enough of them, fellowships and clinical chief information officers, whether they be consultants, GPs, allied health professionals, nursing teams, but we've had to make sure that we have provided the fellowships in order for them to build those experience with the core specialists. And then we know that we need to make ongoing training and moderation, because the transformation and the change management that sits behind all of these platforms doesn't happen overnight. We have certainly recognised that you can't just deploy something and expect the workforce or the population to take that on automatically. It takes time, and actually it's all of the business intelligence and data that sits behind it that shows us whether we're actually developing that knowledge and that capability within the teams, and that whether it's being applied properly, and that's shown in the ongoing use of those technologies going forward. So as a system, some of the technologies we're building ourselves. Our personal health record, we are building ourselves. And so we have or ongoing recruitment for testers. We definitely work with our community and our charity and our third sector organisations to create more of a room within our workforce around the adoption and the awareness, and also to support the digital literacy development so that we're not leaving anybody behind. And then also to make sure that we're double checking our designs back with our population and that they're happy in the way that we're taking things. So I'm going to stop sharing there because that is the end of my presentation. Any questions?
Well, thank you very much. It was a very comprehensive presentation. Quite a lot of things that you have under your shoulder, I guess. So I don't know, Dimitris, do you have any questions?
Quite impressive, all this, and well organized. It's more or less connected with the NHS GP Online we have read last year or the year before last. That's really impressive, and we expect to hear the results concerning the quality in care, and because concerning the people adoption, I believe that most of the citizens of UK will like it. But I'm not sure about what are the results concerning the quality of care and how it is improved. And also, if this is used also in the secondary care, except the primary care health.
Yeah, a really good question. So the data that we've had back so far shows that it's still increasing in the use and the adoption of all of those different technologies. Surprisingly enough, in terms of the patient portals, we actually have the highest group is between 60 and 80 that are adopting the technology. But we do have some data quality issues because we need to be able to make sure that they're being coded effectively. So sometimes between all of the organisations that you might get some groups that code, well, I've responded to online consultations using an email, or then the patients had to return for some reason. So they then ended up seeing them face to face. So whilst we can see that the activity is increasing and we can see the age groups of those that are actually adopting it, we do have some data quality issues in order to really fully address the impact. In terms of the workforce, we did some rapid insights with our academic health science networks, and the workforce are finding their way in how to apply online consultation and video consultation in its appropriateness. So primary care are absolutely the dominant areas of change, but yes, our secondary care providers are using it too. So they're using it in their outpatient transformation, understanding that actually now they don't have the capacity to be inviting patients back to do their regular reviews. So they're moving them to remote monitoring instead, doing the education online, and then asking the patient to nudge the clinical team if they notice that something's not quite right with their condition.
Okay. Thank you very much. I cannot see any comments or any questions from the audience. And I'm not sure if it is a technical problem or if we don't have comments, we don't have questions. We are so ahead that we don't have comments.
So, in any case, I think we had a very nice session, very informative. I think the session has been recorded and potentially will be put on the site of the conference to be revisited and reviewed again in the near future. So I would like to thank all the participants and presenters for their excellent presentations and the effort that they have given to participate today here. And I leave to Dimitris to say a last word before we close.
I think that more or less it's the last session of this scientific meeting, but probably it's the way and the future we should follow, we should go on. So I want to thank you all. Don't be sure that not having question, not having comments, it is something that it is not good. Usually this is something that needs time in order to have questions, and probably you will have mails from people they want to follow and they want to comment on that. Thank you anyway, thank you all for being here, and thank you. We have to thank you also for the hospitality for being there. So I hope we will meet again in a future meeting. Thank you very much.
Thank you very much. Bye-bye.